Excellent. And thank you both, Steve and Keith, for such an excellent presentation. We have some questions from the audience. I have a quick question for both of you, and it's about policy and what's the role of policy. Can we regulate weight bias? We have government policy. Sometimes they're too broad, ineffective, difficult to enforce at a national level. They're prone to the influence of politics. We also have, like you mentioned, institutional policy, which are closer to where people are. They know the industry, they're easier to monitor, but then they have the caveat that you're relying on self-policing, and that's also a challenge. And then there might be other, and this is where, besides these two approaches, are there any others? Maybe using accreditation, other ways for us to, in a more systematic way, break down weight bias. So, Steve, you can start, and then Keith, and then we'll take some questions from the audience.
I guess this is where international differences play a part, I guess. I mean, in Europe, we are a bit more open to labour market regulation, for example, perhaps less so in the UK than in Scandinavia, for example. But back in a few years ago, there was a ruling in the European Court, which was based on a case brought by a Danish nursery worker who claimed that he was dismissed from his job because of his obesity. And it's called the Kaltoft ruling. And essentially, the court found in his favour. And so it's enshrined in the European law that obesity should be treated by employers as a protected characteristic under employment legislation. The UK hasn't quite gone that far. If you have a comorbid condition such as osteoarthritis or hypertension or type 2 diabetes, which is likely to be triggered by obesity, then those are protected characteristics, and employers need to make sure that they're not discriminating on the basis of those conditions. But certainly across most other European countries, the idea that obesity should be a protected characteristic, that employers have to make reasonable adjustments to help some people to accommodate any functional incapacity they have or psychosocial problems they have, and that their workplaces or their working time might be adjusted to accommodate any impairments they have as a result of their obesity. So governments can do things like that. Obviously, it does also require enforcement to happen, and also for case law, obviously, to develop as tribunal or employment law cases are brought. So that's a sort of, I suppose, what you might call the stick rather than the carrot. I think there's much more that can be done in terms of, government-sponsored public health messaging, and making sure that public health messages, of course, will focus on things like nutrition and self-management and education and so on. But also recognising, for example, a thing we haven't really talked about is the strong genetic component of obesity for many people. Recognise we need to take a perspective on this, which is about what obesogenic environments we have, how health inequalities play into obesity, and shifting the emphasis towards those policy interventions rather than just focusing on individual behavioural change, which we know doesn't have a sustained impact.
Thank you. Keith?
Yeah, again, very challenging issues. So I'll start inside and move back out maybe. At institutional, because it's a lot easier, as you mentioned, Carlos, at an institutional level, it's somewhat easier to control policies and at least to examine existing policies that may be inadvertently promoting bias and discrimination against weight, and then to modify those, right? And so that's one thing we need to do. And then hopefully that will lead to a set of practices that are also less biased and more inclusive and welcoming. When we think about, again, for society here, what we do each and every day what we do is we reflect the conscience of our society, right? And so and it's up to us. If we want it to be different, then we need to look at the laws and the policies that we have and make sure that they are not discriminatory or biased, or at least to make sure that they don't allow for discrimination and bias. Now, at a local institutional level, it's a lot easier to do scorecards and dashboards where one can look at any disparities related to weight bias and be able to show that. And then internally, one can look at, do we set up structures that maybe help promote good behavior rather than to demean bad behavior? And we probably can do that a little easier within an institution or within a setting or a department than we can at a greater societal level. But those are things we need to be thinking about, and things that should at least be put on the table, as Steve just mentioned.
Great, thank you. Appreciate. So we have our first question from the audience. This is for you, Steve. It asks whether this wage gap that you presented are consistent across different professions, or is this more exacerbated in different specific fields or positions?
Yeah, it's a really good question. And then the more we looked into this, the more the evidence is really compelling, but also it's possible to see patterns. So we didn't really go looking for example, the life course journey and the fact that the wage penalty follows women particularly through the life course. We did find that the wage gap was more amplified in jobs which were lower skilled and lower paid to start with. Tended to be in sectors such as hospitality, retail, and so on, which are more customer facing. So back to my point about the aesthetic labour market, perhaps less pronounced in more professional white collar roles, but it still existed, and certainly not experienced by anything like the same degree amongst men in any sector or any socioeconomic status. This is predominantly a female issue, but as I say, in lower skilled, low paid sectors.
Great, thank you. Keith, we have a question for you. It says, doctors oftentimes hand out a one-size-fits-all weight management plan that doesn't always take into account the whole person outside of the weight concern. This often sets patients up for failure for many reasons, increasing frustration on both sides and leading to a disconnection from the medical system on the patient side. So what is being done to change this in how today's medical students, and you're at the UCLA medical school, how do we train medical students? And is this an issue only for those training in bariatric medicine, but also is something that is applicable to doctors in primary care, OBGYN care, even pediatricians?
Yeah, no, I think that's it's a great question, and I think embedded in that question are sort of all the answers. I think but I think that individual brought out a great point, right? That we can't use a one size fits all solution, right? Everybody gets to a certain point through a different pathway. And everybody has, and particularly when we're looking at these complex medical problems, there are a variety of different factors in society, from the different social determinants of health to the different ways in which bias and discrimination are being levied upon an individual. And so to think that one solution will work for everybody is the problem. And so so what we're seeing now in medical education is to try to really emphasize the importance of individualized care, right? So we have a sense of a condition and a variety of the factors that may influence it. Now we need to find out for our individual patient what is going on in their life and what do we think would be the most likely interventions or recommendations to start with. And a lot of times this is a joint decision, right? We call shared decision making, because the patient frequently has a sense of what the barriers are, what elements are most burdensome to them or feeling most burdensome to them. And so understanding that, then it gives us an idea of what recommendations we might make and what other sectors or colleagues we need to bring in to help this individual achieve whatever goal we set up, right? So we also need a common goal set up and then figure out who on the team needs to come together to make that goal a reality.
Great. Thank you. So we keep having questions here. So this is, I'm going to switch to Stephen. Are there opportunities to connect employers' standard wellness programming to medical benefits, and what interventions and employer coverage to eliminate bias and discrimination are out there? It seems like they're two separate silos and they actually complement one another.
Okay, well, I guess I should start my answer by saying that I'm from the UK, so I'm far less familiar with the deep-seated intricacies of US companies' healthcare systems and health promotion. I'm aware of some of them. I mean, it does seem to me that some of this is about the design of worksite health promotion initiatives. Clearly, in the US, the financial burden borne by American companies in terms of healthcare costs is very high, so there are very strong incentives to do things that aren't just about providing a sort of soft and cuddly benefit and giving people a warm glow that they're being looked after. There's an interest in actually shaping, changing some of the health metrics. So, the way you do health risk assessments, types of biometric, biological measures, medical indicators that you collect. They're very active doing that can reinforce stigma potentially. So you have to be really careful about how you do that. That's far less common in the UK context. We tend to have two types of health promotion interventions, those which are seen as a staff benefit, i.e. helping the employer compete in the labour market. They don't tend to include things like private medical insurance quite so much as they do in the US. It's about giving a sense that you care about your employees as a way giving yourself competitive advantage. Those are almost never evaluated in terms of health outcomes. They're measured in terms of take-up, participation rates, and so on. Most employers who measure that couldn't tell you whether it made any difference at all to people's health. There are other types of health promotion interventions which are focused on reducing psychosocial risk, musculoskeletal strain, and they take a much more methodical approach. We're looking at workplace risks, having mitigation, and then measuring outcomes such as sickness absence, presenteeism, and labour productivity. I think in both of those situations, the mistake that organisations often make is that they regard ill health of any kind as a burden, and as a risk that needs to be mitigated. They don't focus on what people can still do despite the fact they're living with rheumatoid arthritis or multiple sclerosis or cancer. They catastrophize and sometimes over-medicalize the problem. And so I think that employers really need to think a little bit more about how obesity plays in that scenario, because seeing it as an illness can in some ways be beneficial and can inform employers about what they do, but actually focusing on what people can still do despite any impairment they have is a far more positive way of thinking about it, and one of the ways we can start undermining stigma and discrimination.
Thank you. Got some very lively questions here, and we're almost getting to that time where we need to close. But I have one question here, probably one last question for Keith, and it's a little bit of behavioral economics, and it is how do we hold patients accountable without incentivizing them? And the example, the person asking the questions is for a nutrition physical activity program that they were having patients complete goal trackers for accountability and to help them be more successful by giving them incentives if they completed the trackers. This person is wondering now if they should if it's okay to continue to do that.
I'm thinking it's probably okay to continue. I think the challenge is we think that from a healthcare perspective, that we have an ability to impact weight loss in a way that we usually can't. Because for most people, the reason why they gain weight has nothing to do with us as a physician. It has to do with a lot of other factors. And frequently this is a maladaptive coping mechanism with other stressors and other factors that are going on in society, right? That then gets amplified by the biases, the structural biases that are built in. And so what we're hoping is that some recommendation we make can overcome those. And we see it overcome in some, there may be some patients in which it does overcome those. And then we wonder, well, why aren't all the patients, doing better? And the reality is we were just lucky that those few did better, because we really didn't address the real underlying cause. We may have addressed an intermediary cause and it may have worked for a person. So I think the most important thing is we need to be thoughtful when we think about what are the types of incentives and structures we're putting in place, and where along the spectrum we think that's intervening, and therefore have a realistic sense of what the likelihood is it'll make a difference.
Yeah. Thank you. It's been a great discussion. I'm extremely thankful to the speakers and the thoughtful questions. We're going to take a 30-minute break now, and we'll reconvene in half an hour. This will wrap up, and we'll have another panel, and we'll have some reflections and with the workshop planning committees and other members. But I want to make sure that speakers realize we really appreciate their contribution. Thank you very much.
Thank you, Carlos.